So everyone be on your best behavior now.
Yeah, all right, this is forever now.
Yeah, this is forever. No, but that's funny that you were asking these questions, because that's how I was going to actually introduce Dr. Raskin, except I will also add that he is on our medical advisory council and also has spoken at our consumer conference. So it's always great to have you come give a chat, kind of like a very informal chat where people can submit questions ahead of time. And I know you've got some slides to share, and you will also have some time for open discussion. So we'll go through all of that. But again, welcome everyone to our virtual chat. We had a bit of a hiatus, but we are back. And so today's topic is pediatric. Well, that's such a big title. I think that maybe I'll just let you kind of go through everything yourself. So Dr. Raskin, I'm going to hand it over to you.
No problem. Let me share my screen here. My experience with this group is that it is awesome. It is an awesome way to interact with families and patients, and kind of market direct to consumer, if you will. It's basically my ability. I just really revel in this ability to talk directly to families and patients affected by epilepsy, which is what usually the audience is for these particular talks. And the reason for that is that it's a group of patients who are incredibly underserved, in that the rate of medical refractory epilepsy or drug-resistant epilepsy is about 30%, 30 to 35% of patients with epilepsy, which is about 1% of the total population. And these patients generally don't get referred for surgical treatment, which is really, really effective. Even our worst therapy, which is vagus nerve stimulator, one of the things we're going to talk about, is 3 times more effective than just adding on another medicine. So I'm very passionate about this. I'm very excited to talk to people about neuromodulation in general, open it up to questions. This will be neuromodulation with respect to epilepsy treatment of pediatric patients. I have a couple institutional grants, and I'm the president of a 501c3 that's not relevant for this talk. Just to start, I need to frame this because everyone will come with a different knowledge base, but what we're talking about here is patients with medically refractory epilepsy. And epilepsy, just to define it, is a seizure disorder where there is a hypersynchrony of neuronal discharge. Basically, a bunch of neurons firing together that don't belong firing together. And then they activate other areas of the brain, leads to network activation, and that activation of the network manifests as a seizure. Seizure disorder is multiple ones of those, and that's called epilepsy. The treatment goal for seizures and for epilepsy in general is no seizures and no side effects. Yet we know, and I just said before, that about 30 to 35% of patients will not respond to medicines and or dietary therapies alone and progress to have drug-resistant epilepsy, or something called medically refractory epilepsy. And these are the patients who benefit most from surgery. We know, especially in children, that ongoing seizures and the medications to treat seizures profoundly affect the developing brain. They create mood disorders. They stigmatize patients. They prevent them from getting appropriately schooled. They prevent them from learning normal behaviors. And these patients are significantly affected by medical refractory epilepsy. It is bad for the brain, okay? It's bad because of recurrent seizures, because of missed schools, because of all the mood disorders, and because of all the medications that are necessary to treat all of these underlying conditions. I always tell patients that no brain is better than bad brain. And what that means is brain that is causing seizures is not performing normal brain functions and is disrupting the normal brain functions of the rest of the normal brain. So that brain has to go. It cannot stay behind. These patients have a developmental plateau, often regression, and develop things called epileptic encephalopathy, which is very dangerous. Of course, it's also associated with SUDEP, sudden unexpected death from epilepsy. The goal is, of course, seizure freedom, but if not seizure freedom, seizure reduction, and reducing the burden improves quality of life. It's not the most important thing, but it does improve quality of life. And then in children, the younger the better, and I'm going to show some slides about that, but the younger the better, in order to capitalize on the plasticity of the developing nervous system. And this is Jerome Engel, like one of the most famous epileptologists, neurologists in the world, who has this quote, and if you want to visit him online, he has like a 10-minute talk here where I got this from, but it's the tragedy of the United States and other industrialized nations is that only 1% or less of these patients, medically refractory epilepsy patients, are referred to specialized epilepsy centers. And this is a travesty. We have the highest level of evidence for seizure surgery in the form of randomized control trials proving safety and efficacy of epilepsy surgery. Yet we still don't see the influx of patients that we expect to see and that frankly should be seen for the benefit of the population. And I just also highlight in this slide that the goal of seizure therapy in general, even with just medications, but medications and surgery combined, is no seizures and no side effects. And that's not just my opinion or the opinion of a group of North American neurosurgeons. That is the group called the International League Against Epilepsy, a multinational conglomeration of epileptologists and neurosurgeons and others who define what it means to treat epilepsy across the world. At Lurie Children's, we have a roadmap for our epilepsy program, and it starts with number one, the diagnosis of medical refractory epilepsy. And after that, you get funneled into our program where we perform a certain phased workup, phase 1, 2, 3, 4. I'm going to talk about those phases in a bit more detail. But what this slide is meant to show is that there is a structured workflow or roadmap through the process. So when you are taken into the program, it's not like you're confused or you don't know what's coming next. We kind of walk you through each step of the way. If you make it as simple as possible, there's 4 phases to treatment. Phase 1 is a pre-surgical workup. Phase 2 is not always necessary, but sometimes is, and involves the placement of intracranial electrodes. Phase 3, if you have intracranial electrodes, would be bedside mapping. And phase 4 is a therapeutic surgery. Sometimes patients proceed from phase 1 to phase 4. This means that patients have all concordant data. So for example, a patient with temporal lobe epilepsy coming from the temporal lobe and a lesion in the temporal lobe, they might go straight to a temporal lobectomy. That has like very high evidence that it's successful and effective. It's very safe. It's much, much better than treating with medications alone. There's level 1 data that suggests that that is an effective strategy and that patients should undergo that particular treatment. That's not who we're talking about today. We're talking about patients who do not have a very clear path from phase 1 to phase 4. These patients need a more palliative approach in the form of neuromodulation. Just to like fully characterize the first phase or the pre-surgical phase, it involves 5 things: a history and physical done by an epileptologist, a video EEG, the patient has recorded EEG in the hospital, structural imaging like an MRI scan, 3T Tesla MRI, functional imaging, which could be any number of things like a PET scan or SPECT scan, a MEG scan, and then a neuropsychological evaluation. Where we try to identify the area of excessive neuronal synchronization. Again, that's where a seizure comes from. That's the seizurogenic zone or the ictal onset zone, the area that's causing seizures. We try to identify that and then destroy it, or in today's discussion, modulate it. And when you talk about neurosurgical procedures to treat epilepsy syndromes, you basically have 4 buckets. There's resection surgery, which I already talked about, is basically temporal lobectomy. Anytime we're resecting or removing a piece of brain and some surrounding tissue around the lesion, for example, that has a very high surgical cure rate for epilepsy. And if you're fortunate enough to have a lesion that's causing epilepsy, you belong in that bucket. Disconnection surgery is sometimes curative and sometimes palliative, just depends on the individual patient, but involves corpus callosotomy and hemispherotomy or hemispherectomy. Not really done very much anymore, but hemispherotomy is certainly done quite often. I'll skip number 3. And ablative surgery is MRI-guided laser interstitial thermal therapy. This is commonly called laser surgery, or something that's just on the horizon and is being used increasingly more commonly in the clinical setting as MRI-guided high-frequency ultrasonography, where we use sound waves to disrupt brain tissue and create thermal lesions. Going back to the 3rd bucket, neuromodulation. It has its own bucket of surgical procedures that we use to treat epilepsy. And what we're going to talk about is invasive strategies like vagus nerve stimulation, responsive neurostimulation, and deep brain stimulation. First, we should just define neuromodulation quickly. It's the process of modifying neural activity using technology. This is a very simplistic view of what neuromodulation is. Technically speaking, it's allosteric, meaning that we're applying something not to the synapses or the normal ways in which neurons communicate, but we're modulating nerves and brain tissue in a different way. There are multiple ways to do this. You can apply electricity, that's what we're going to talk about today, but there are also the applications of magnetism, different medications like baclofen, for example, and also thermal energy, like low frequency ultrasonography, where we try to just disrupt things in a much more sophisticated way than I just described. But that being said, there's multiple ways to affect neural activity or produce allosteric neuromodulation. There are invasive and non-invasive strategies for the purposes of treating epilepsy. Basically, the only good evidence supports neuromodulation, invasive neuromodulation with VNS, RNS, and DBS. And the non-invasive strategies like transcranial direct current stimulation and transcranial magnetic stimulation, these are not well supported by evidence. The specific limitations in pediatrics of applying neuromodulatory devices are that the FDA lacks approvals. It lacks FDA approvals because it's considered, not ethical or worthwhile in the company's interest to obtain an approval for pediatric population. They sometimes go back and try to get adolescent or pediatric FDA approval after they get FDA approval for patients who are deemed adults 18 and older. But for the most part, we'll talk about who is FDA approved and who is not FDA approved for neuromodulation. All of it is adult hardware because probably of the FDA approval system and because the population of adults is better reimbursed and far more common than is the pediatric population. All of the hardware is sized for adult skulls and adult scalps. So we have to use that hardware in children with thinner skulls and thinner scalps and different quality of their brain itself and so on and so forth. So we're always kind of adapting adult hardware to pediatric patients. And it is true that pediatric tissue is not the same as adult tissue. It has different myelination, has different water content, has different electrical processing, the circuits are different. And so that is an important thing to know about the differences between neuromodulation in adults and children. And then finally, there are longitudinal care issues that exist in children, which we really can't understand right now. And that's, what is the effect of, for example, in responsive neurostimulation, opening and closing the scalp multiple times over the course of that child's life to change the battery that will need to be changed every, on average 9 years for an RNS. We don't know what impact that will have on the durability of this sort of treatment. If you look at neuromodulation, it goes back, thousands of years. If you look at early sort of scientists using electric fish to stimulate and try to affect some sort of physiologic change in people. But it wasn't really until the 18th century with Galvani and Volta who really started to understand the electrical signaling in the human body, particularly in the heart, and then the application of that to the central nervous system through early on deep brain stimulation to treat pain, further evolution in our understanding of the gating theory by Melzack and Wall helped us understand that we could stimulate the spinal cord, for example, and change our perception of pain. And through this application of early investigation of electricity to the central nervous system came our decreased understanding of the central nervous system by causing lesions. And so this kind of helped evolve an entire industry and lead to the FDA approvals of spinal cord stimulation in 1989, and then motor cortex stimulation in 91, vagus nerve stimulation in 97, responsive nerve stimulation in 2013, and deep brain stimulation in 2018. So it really can be said in epilepsy specifically that we're in an era of neurostimulation. And what does that mean? Well, a lot of it we're still trying to figure out. But what it does mean is that we understand some of the implications and impact of stimulating the central nervous system. High frequency stimulation changes cerebral blood flow. It suppresses synchronous neuronal firing when you stimulate in the thalamus, and you can actually affect the location and transcription of receptors like GABAergic benzodiazepine receptors, which have an inhibitory effect on brain. And so we really are starting to understand these like physiologic and substructural impacts of stimulation as it reflects on the modulation or disconnection or remodulation of normal circuits in the brain. So there's 3 types of neuromodulation to discuss. The first is vagus nerve stimulation, FDA approved in 1997 as an adjunctive treatment for pharmacoresistant epilepsy. The current battery is that one down in the bottom right corner. There's that one in model 106, but the DemiPulse down there, the model 1000, the Sentiva model 1000 is the most sophisticated VNS battery on the market. It's quite small. It's perfect to place in really tiny little kids where there's not a lot of subcutaneous or submuscular space to put a small battery. The VNS is indicated in patients with intractable epilepsy who are poor candidates for resective surgery. So this really is a palliative approach to patients who are not intracranial surgery patients. And we apply it to basically everybody who is not an intracranial surgery patient who has continued epilepsy, despite appropriately chosen and well-trialed medications in patients with multiple bilateral independent foci, generalized epilepsy, idiopathic and cryptogenic epilepsy, and failed intracranial epilepsy surgery patients. And it has been deemed by multiple different studies, including a Cochrane review, that summarizes it as effective and well-tolerated. It is now approved in children above 4, which just means that it is FDA approved and labeled for children above 4. But we implant vagus nerve stimulators off-label in all patients who have an indication. I've done implantation in a 6-month-old and a 2-year-old, and it is also covered by most insurances. There is comparable efficacy in children as there is for adults. And with application of a vagus nerve stimulator and aggressive anti-epileptic drug regimen, more than 50% of children will achieve at least a 50% seizure reduction. The complication rate is very low. And just to highlight here, a vagus nerve stimulator is basically 2 incisions, one in the anterior neck and one in the chest somewhere. You put the battery in under the skin in the chest and sometimes under the muscle if they're very, very thin. And then the electrodes get wrapped around the vagus nerve, which is right between the carotid artery and the jugular vein. And it's a very highly conserved size. So it's basically nearly the same size in an infant as it is in an adult. And it's easy to find. It's anatomically present. We do it on the left side, basically left side only, because about 90% of the nerve fibers go up into the brain in what we call the ascending vagal network. And they work when we stimulate that through different nuclei, nucleus tractus solitarius and locus coeruleus, and it works to go through the brainstem and modulate or desynchronize the brain. That's how we think it works. It turns out that not only do patients respond, which means that they have a 50% reduction in seizures, but there is a seizure freedom rate associated with vagus nerve stimulators. And if you look at that box on the left, you can see that there is about an 8% seizure freedom rate over 48 months. And just to put that in perspective, there's about a 3% seizure freedom rate with just the addition of another medicine. So that means that there's at least 3 times higher seizure freedom rate at 4 years in patients who have a vagus nerve stimulator versus patients who don't. And it turns out if you look on the right, that patients who are implanted in less than 10 years actually do better than patients who are implanted in more than 10 years, indicating that it really doesn't matter how long you wait to implant a vagus nerve stimulator. The earlier, the better. So just to conclude vagus nerve stimulators, it's FDA approved in children 5 and older. It's indicated in patients with intractable epilepsy who are poor candidates for resective surgery. It's palliative, as all neuromodulation is, and it basically respects the 50-50 rule, which is about 50% of patients will get about 50% seizure reduction. And that seizure reduction increases over time. About 4 years, about 60% patients are responders. There's a seizure freedom rate that is 3 times higher than just continued failed medication after failed medication. Generalized seizure syndromes respond a little bit better than partial onset seizures. The surgical risk associated with the implantation is quite low, very low infection rate. I think it's actually probably more like 2% in national data, and certainly here it's very, very low. And then there can be some vocal cord irritation that generally gets better over time. Deep brain stimulation, I'm going to highlight it next, although it was only FDA approved here in the United States in 2018. It's been FDA approved overseas and in South America since the Sante trial in 2010. So it's been applied to a huge volume of patients internationally. It's just here in the US, it's only recently been FDA approved. Basically, deep brain stimulation for the purposes of pain, I already highlighted. It's been studied for a long time. For the purposes of epilepsy, we have different prospective randomized trials involving central median stimulation as well as anterior nucleus of the thalamus stimulation. And these stimulate different thalamocortical networks, which means the thalamus and the cortex are constantly in communication. Seizures generally don't happen in the thalamus, but when they're activated in the cortex, it goes through the thalamus. And if you have electrodes in an appropriate nucleus in the thalamus, the idea is that you can desynchronize those seizures. And this has been found to be very effective. And this is kind of what it looks like on stereotaxy. This is our intraoperative computer guidance. This just happens to be Medtronic, but there's lots of ways to do it. These electrodes happen to be in GPI. I could not find my electrodes that were in the thalamus, but you basically just target using this cool software. You target the subcortical nucleus within the thalamus or the GPI, basal ganglia, wherever you're targeting, and then you use modern stereotaxy to achieve those trajectories. And typically, accuracy is extremely good, submillimetric or less than 2 millimeters. The Sante trial is the trial that led to FDA approval, although it was quite delayed. The Sante trial showed that in adults, again, FDA approval in these like DBS study group trials and so on, they don't include children. They subsequently sometimes go back and get approval in adolescents or children, but it doesn't necessarily matter. We still use it off-label. But in this group of adults, during the 3-month initial blinded phase, it showed a seizure frequency decrease of 40% in the stimulation group and 14.5% in the control group. And then when they opened it up, it was more than 50% in the stimulated in everybody at 2 years. So big difference in seizure frequency. It's, resembles the treatment effect with vagus nerve stimulation in that over time, neuromodulation seems to work better. And then it was FDA approved here in 2018. The European results for children are on par with the adult data. And so in conclusion, the deep brain stimulation has FDA approval here in adults, of course, for epilepsy, and we use it off-label in children all the time. Temporal lobe seizures do respond best using the Sante trial data, although that data really includes stimulation of the anterior nucleus of the thalamus. And children were much more likely to stimulate central median nucleus. And there's a lot of evidence that that is also effective. And in particular, patients who really have severe manifestations of epilepsy, like in the setting of Lennox-Gastaut syndrome, there are multiple double-blinded studies, including children, that show that this is a very effective therapy. Finally, NeuroPace, the quote brain pacemaker, a responsive neurostimulator, has both names. It is the only closed loop brain responsive neurostimulator system, which means that it can both sense the electrographic correlate of a seizure and stimulate in order to desynchronize that seizure. It has initially, once you implant it, it has a period of time where it is learning what your seizure looks like, and that is guided by an epileptologist as well as the representatives of the company. Patients do have to upload their data once a week. So the device lives in the skull, and then it can accumulate data over the course of a week or so, but then it has to be uploaded to the cloud, where physicians can remotely view the data, and also the technicians can help understand and contextualize what it is that we're seeing. This is kind of what the device looks like. It is a battery that lives in the skull. So we remove a piece of skull and put the device in where that piece of skull was. It can connect to 2 electrodes, either a strip electrode or a depth electrode. They have varying lengths and you would use a varying length depending on the size of the head or the distance away from the device where the electrode needed to be in the brain versus the device. If that distance is very far, you can use a longer lead or a shorter lead. They all have 4 contacts. So each lead electrode has 4 contacts. The 9-year data for this is extremely effective. So also FDA approved for patients age 18 or greater, but NeuroPace, the company, is actually seeking right now an adolescent indication. They're kind of going back saying, look, we've implanted this in a lot of patients who are less than 18. They're doing very well. It has a very high safety rate. And so we'd like to ask the FDA for approval to a lower age group. This is a common way of going about getting a pediatric indication, and that's ongoing. But overall, 75% responders, which again means that there was a 50% reduction in seizures, not seizure freedom. But with this particular therapy, 18% seizure free at 1 year. So that is 6 times higher than just treating with medication after medication after medication. And so this is a very effective therapy for selected patients. This is a patient where I did a temporal lobectomy and implantation of a responsive neurostimulator, just to show you on X-ray what that hardware looks like. You can see right here, there is a craniotomy with little metal screws and plates to keep that bone back on afterwards. And then this is what the device looks like on X-ray with 2 electrodes going into this part of the brain, which was causing seizures. And this is what it looks like in real life. And this is the data that you get from it. So basically it's in sense mode here on the bottom. You can see each long episode corresponds to a seizure. So as it's sensing, it's learning what the long episodes look like. And then you turn it on, and then it desynchronizes those seizures. So it doesn't record any long episodes anymore because it senses the long episode and then it stimulates so that the seizure doesn't occur. Then this is in July and August down here at the end of the curve. This is a combination of non-compliance and medication changes. So it can actually like measure how effective a certain medication is. Because if you're having a certain seizure volume, you take medicine and it drops that seizure volume, right? That will make an objective difference on this graph. And then usually with medicines over time, they start to not work as well. And then you would see that on this graph of the histograms. Talking about neuromodulation in general, this is a prediction from Granby Research, which is a 9% compound annual growth rate of implanted devices, including deep brain stimulators, spinal cord stimulators, and vagus nerve stimulators from 2016 to 2028. So more and more of these devices are being implanted. They're being implanted for various current indications, as well as for increasing indications like Alzheimer's disease, obesity, alcoholism, etc. And then this is just a very short case that I wanted to show and highlight how do we conceptualize neuromodulation in the context of these very complicated patients. So this was a patient, a little girl, 11-year-old girl who had basically hemispheric involvement on her EEG, and she had just a couple lesions. And we decided that we didn't have enough data to offer her a therapeutic phase surgery. So we offered her a phase 2, which was implantation of depth electrodes called a stereo EEG. This is what it looks like. Basically, this is our plan on her head. And then these are all the different electrodes that go in, including this one here, which was in the centromedian nucleus of the thalamus. And you can see it in line, in something called a view along. And it comes down here and terminates in the centromedian nucleus there. this is all the data that we get. So during implantation, these are all the various numbers, all the names of the electrodes that we use in order to make sure that everything is very safe and accurate. And this is how we do it. We send out this list of instructions and needs to the anesthesiologists and the nurses and everybody, so that everybody's on the same page. Then this is what the data looks like for an implanted patient. You can see these waveforms are very sensitive. Each one of these groups is a single electrode on which there are multiple contacts. The contacts vary from 4 to 10. And you're seeing just this is normal brain activity for this particular patient. And then on the right here, you're seeing like a 3D rendering using our brain lab, which is a form of neuroimaging that we use to identify exactly on this patient's brain, where are these electrodes and which part of the brain are they all in. And this helps us understand when we get seizure data, which are the contacts that are very active. And so we can kind of break it down. So these red contacts were the most active. These in neurosurgery are very far apart, basically temporal parietal occipital area, temporal area, frontal area, very far apart. The second most common contacts were different, but also just as spread out, as is the case with the third. So for this particular patient, you can't really offer them a single resective surgery or anything that will be impactful in their overall seizure disorder without causing a significant deficit. This is a walking, talking, going to school girl who has a terrible seizure disorder. But if we just remove the right cerebral hemisphere, then she won't be walking, probably not talking, right? Very severe deficits at 11 years of age. This is a perfect case for neuromodulation because we're seeking to affect the way the brain is functioning without changing the underlying condition of it. So we don't want to change who she is or the function of all the normal brain that's admixed in the abnormal brain. And so we basically explant all the electrodes, and then we create this three-dimensional GPS system around her head. That's called stereotaxy. We replace the electrode in the centromedian nucleus and then hook it up to this battery. This patient discharged home 2 days later, and 4 months later, the device is on and working, and she's having fewer seizures. So just to highlight, seizure surgery is safe and effective. The chance of having, seizure freedom after a third or fourth or fifth or sixth medicine alone is only about 3%. Whereas with our most palliative therapy, where we're not even doing brain surgery, we're just hooking up electrodes to a nerve that then stimulates the brain, is 8 to 10%. We'll call it 9%. And that's 3 times higher than a medicine alone with a very low risk. DBS is somewhere in between, and RNS is about 18%, as I presented. But the overall responder rate, again, 50, 60, 70% responders, meaning a 50% seizure reduction using neuromodulation techniques. There's a lot of differences between these 3 devices. Just to review, VNS is FDA approved in patients over 4. RNS is approved in patients over 18, as is DBS, but we use them off-label all the time in very young patients without any consequence and with similar benefit. This is outdated. These all are MRI conditional, including responsive neurostimulators now. So that is a labeling, a labeling addition that's different now for RNS. And then these are the 1 year 50% reduction in seizures. Vagus nerve, all pretty similar. Vagus nerve 34 to 37%, RNS 44%, DBS 43%, and then that improves over time, as we talked about. Just to conclude, neuromodulation is safe and effective in children. Time to implant matters. The sooner, the better. And there's even more data that suggests that within a year of diagnosis of medically refractory epilepsy, patients do better if they're implanted, less than a year versus more than a year. When the data I showed was less than 10 years, more than 10 years. 10 years with a medically refractory seizure disorder and no surgical opinion, I think, is just wrong. It was just absolutely wrong. The complication rates for these devices and basically for all neurological surgery in the modern era is extremely low, especially compared to the benefit that these patients can see. And then we've talked about the FDA labeling, and all devices have a higher seizure freedom and responder rate than continued failed medications alone. At Lurie Children's, we have a busy epilepsy center. And these are the numbers if anyone wants to call, and you can refer yourself to our epilepsy program, and we will do an intake and figure out what tests we need to order and get that worked out. And this is my email. Please don't call me, but you can if you want. I may or may not answer. And that's basically it.
That's awesome. Thank you, Dr. Raskin. That was a really great slide deck. And you definitely answered a lot of the questions that I personally had. I know there's a lot of people on the call that have questions for you, but I wanted to say that there's two things that I've always taken away from your conversations. One is that phrase that you taught me that sells that fire together or wire together, fire together.
Oh, sure. Yeah.
Yeah, I think that that's a really great visual. And also I love the concept of neuromodulation in general over talking about surgery. I feel like there's a lot more potential, a lot more possibilities when we talk about neuromodulation. And I feel like it's not so much of a dead end. Like there are a lot of options for people, and you've just laid out a ton of options for people.
Yeah, that's right. Yeah, there's a lot of, I mean, the modern application of neurological surgery has gone far beyond craniotomies and sweeping scalp incisions of the past. We really understand quite a bit more. What we don't understand, we're learning. Technology has become smaller and smaller and more effective. We now have electrodes that have steerable current that are being used and trialed for movement disorders, and probably in the near future will be used in epilepsy patients. And, with the advent of high frequency ultrasonography and our ability to make lesions inside the brain very, very accurately without actually making any incisions whatsoever, I mean, the technology opportunities and applications for epilepsy is tremendous. And the only way patients will benefit from it is if they come and see us in our clinic.
Right. And at the foundation, it's something that we really are pushing, that, just the concept of medical refractory epilepsy and just getting to your epileptologist. And sometimes even that is a conversation. People don't really understand who that person is, but we are really trying to push for people to ask questions. And on the note of questions, so folks can definitely type in their questions, or if you want to come off mute, I know there's a question in the chat box already.
Yeah, so this is speaking specific about lesionectomy. If cortical dysplasia is in an area where removal could cause a deficit during surgical evaluation, are you able to tell exactly what that deficit would be and how significant would it be? Yeah, this is a good question. So this is a quintessential application of essentially responsive neurostimulation. So focal cortical dysplasia is basically a developmental abnormality of the cortex. And sometimes it's associated with a low-grade glioma, but not always. And it can be anywhere in the cortex, including areas of the brain that are non-redundant and extremely important. We call those areas eloquent, like where you use your brain to produce speech or to, form very specific motor units to move your arms and legs, particularly hands. And so if you have a focal cortical dysplasia in one of those areas and it's causing seizures, then removing that may cause seizure freedom, but also will impair your functional ability. And so is it worth being seizure free if you can't speak or understand language? Probably not. And so those are the cases where responsive neurostimulation really shines, because you can put a depth electrode or a cortical strip in or on that brain and use it to neuromodulate that brain. Teach the responsive neurostimulator what the electrographic correlate is of that seizure disorder, and then stimulate it. And so you still have the normal function of that area of eloquent brain, but hopefully the seizure disorder really decreases or is eliminated. And so the question here actually is asking about, would you know what deficit you might cause? In these cases, it's very common to do something called a stereo EEG, which I talked about a little bit. The reason for that is, we think that electrodes to treat seizure disorders need to be very close to the area of brain that causes seizures. And so it's really important to optimize that process. The way we optimize it is we do a stereo EEG. We implant electrodes based on our hypothesis, and then we use those electrodes and that data to understand, where is the best place to put those electrodes. While those electrodes are in place, we can do phase 3, which is bedside mapping, where we systematically activate those different contacts. And that tells us either by negative results or positive results, what area of brain are we stimulating. So for example, if it's in speech, speech is usually on the left side right here. If we have electrodes in speech area and we ask the patient to recite a phrase and we stimulate and they stop reciting that phrase, you can be pretty sure that if you remove or damage that area, that they will have a speech deficit. So that's how we use sort of surgical data to plan or tailor our approaches.
Thank you. Anyone else? So go ahead.
There was another follow-up question that you sent me that asked how many electrodes can you put? So you can put up to 4 electrodes at the time of implantation, but you can only connect 2. So sometimes, especially if we're doing like a temporal lobectomy and then we're going to leave some electrodes behind because, there was a lot of irritated brain, but we can't take it all out without incurring a deficit. Then we would maybe leave a couple behind that weren't connected up and leave some that were connected up. And then in the future, let's say you don't get the benefits that you were expecting, you can come back and just switcheroo those electrodes. That's just mostly a scalp surgery and not like an intracranial surgery. The cost of those electrodes is about $5,000 each. The cost of the device is about $40,000 to $50,000. And the impact of having to do another surgery to implant electrodes, I mean, that's very high, that's very expensive and potentially dangerous depending on what the first surgeries were. So it makes sense to sometimes implant more electrodes than you can physically connect. And then in the future, who knows what these devices do? We as surgeons have advocated that they produce a device that allows for 4 different electrode arrays to be connected up. And I know that they're investigating that, but I'm not sure what stage.
By the way, it's interesting that they asked that because I'm actually typing a literature review currently for cortex mapping. And I never even really considered it in pediatric patients, but I'm sure there may be some differences with how they map it. And I was going to actually ask you about how intraoperative neuromonitoring plays into your practice.
Yeah, it's really, really critically important when you're trying to figure out where motor strip is. When we do awake craniotomies, it's very, very important with awake craniotomies that we actually like physically map with an Ogemon stimulator, or whatever stimulator I guess you're going to use. From like, I guess like it's also more commonly used in tumor resection surgery than it is in epilepsy surgery. So except for sort of cortical mapping, motor cortex mapping, those are basically the main ways in which we use cortical stimulation and mapping techniques in intraoperative neuromonitoring. And then there's a question here from Michelle. I mean, this is a great question. Like, I've already had, what if the patient's already been evaluated for seizure surgery and they, quote, weren't a candidate? I mean, that is interesting. So what I would say about that is that not all programs are the same. Although there's a lot of science, there's also a lot of art to this area. That there are varying and differing philosophies from among surgeons, among epileptologists, within an institution, and between institutions. And so 2017 was a while ago. Since 2017, we have a formal FDA application, approval of DBS for the purposes of epilepsy. We also have a much more sophisticated understanding of basically thalamic network deactivation and implanting electrodes in the thalamus in general, using responsive neurostimulation or deep brain stimulation to disrupt a much wider array of abnormal brain activity. So I would say 2017 was a long time ago. And if there is some generalized seizure onset, it might be that the implantation of thalamic electrodes would be more highly considered now. I know that here at Lurie and also in my previous institution, we are implanting a priori thalamic RNS, which just means like patient has essentially what you're saying here, generalized onset epilepsy, and maybe they already have a VNS. In fact, often they really do already have a VNS and it hasn't really been effective. These are patients where we're actually implanting an RNS system. And it's not just us, it's lots and lots and lots of people. I mean, it's not crazy. It's not even that new. it's just more accepted. So I would say it's worthwhile going to get another evaluation.
All right, thank you. That's helpful. It's a question that's been sitting, at the forefront of my mind kind of nonstop. So thank you.
Yeah, I mean, just to put it in perspective, this year, we'll have done 2 next week. Just, patients come in, implant RNS, go home. And then, so that's like that's not a super high volume, but it's higher than it ever has been in the past.
Yeah, thank you.
Yeah, I think someone asked that question, just kind of the distribution of all your cases, like what, like you have RNS, VNS, like how would you disperse all of those?
Yeah, I looked this up because they asked me. So in 2021, I did 118 epilepsy cases. 32% were neuromodulation in the form of vagus nerve stimulators, vagus nerve batteries, and responsive neurostimulators. We didn't implant any deep brain stimulators for the purpose of epilepsy, but we did implant deep brain stimulators for the purpose of movement disorders, specifically primary dystonia. So 32%, which was like 38 of 118 cases, I think.
And
yeah,
then,
Dr. Kraft, I see you. Yeah, Dr. Kraft is one of my early mentors from master's degree.
Very early, but I'm really proud of you.
Thanks so much.
When you have to go back in and change, quote unquote, the batteries,
Yeah.
since you're doing it in such young patients, is there any problem or side effects? How do you know when I guess when the battery's going down, just like with heart stimulation, right?
Yeah, that's right. The representatives and also the company representatives and also the epileptologists really interact with these patients quite frequently. As a surgeon, we implant it. Now at 6 months, it's not likely to be infected, and we don't really have an ongoing role. The epileptologists do, and they program these devices, and they sort of have a very longitudinal relationship with these patients, and they understand exactly when the device needs to be exchanged. For vagus nerve stimulators, it varies how frequently they need to be exchanged, but it's anywhere from 3 to 6 or 7 years, depending on how much energy you're using. And there's not a whole lot of issue with replacing a vagus nerve stimulator battery because it's in either the soft tissues or under the muscle. And this is an area of the body that has a lot of elasticity to it. Same thing with the deep brain stimulator batteries, but the deep brain stimulator batteries are much bigger, like 2 to 3 times the size of the vagus nerve stimulator battery. The responsive neurostimulator batteries are small, kind of like the vagus nerve stimulator batteries, but they're in the scalp, and the scalp does not have the same elasticity as the soft tissues here in the chest and stuff. And so that is an open question because they haven't really been implanted with any frequency in children since 2013. That device battery on average lasts 9 years. For very high users, it will last 7 years. And for very low users, it will last 12 years. So really, we're just coming up on the generation of patients that really need that device to be exchanged. And so time will tell.
Do you get any kickback from the insurance companies since this is off-label in children?
No kickbacks. No. In fact, we have to argue tooth and nail. I mean, I can show you whole spreadsheets and process maps and everything of how to get these things approved for children. It takes a long time, dedicated efforts from like everybody, including the family. And that's the key, is getting the family involved early.
That's great. You're doing great work. Keep
Hey,
it
thanks,
up.
Dr. Kraft. It's great seeing you.
You too.
I was actually going to ask, are most academic neurosurgeons and physicians in general on salary?
Oh, yeah. Oh, that's, I would say the most ethical way to be a surgeon is to be on salary, because otherwise every surgery you do is impacted by, am I going to pay rent, or I want to buy a new boat, or, you know, whatever it is. I am personally on salary, and that's the only contract I would sign. I don't want to be reimbursed really in any way for doing surgery. I want to be reimbursed for doing my job. Yeah, so academic neurosurgery is not all like that. In fact, in the adult world, it's mostly a pay-for-service type reimbursement model. I would advocate for anyone to, you know, go the other way. But I mean, that being said, all of medicine is pay for service, right? It's a huge industry. It's a for-profit industry. And the only people making out are the insurance companies. And you only want to get me started on that.
Yeah, I actually do virtual billing, and they just will send things back for the most ludicrous reasons, that it wasn't put in a very specific way. They won't just push back the certain things that are billed wrong, but they'll send back the entire thing, just that they can. And it's just a frustration for my parents as well.
Yeah, it's frustrating all around.
All right, so there was another question. So you talked a little bit about neuromodulation for non-epilepsy patients, so movement disorders, so children with autism. So are those outcomes very similar to children with epilepsy, or are they different? What have you seen?
Yeah, I mean, we don't do neuromodulation for the diagnosis of autism, but there is a huge overlap in diagnostic burden between patients with epilepsy and patients with autism. Neuromodulation does not affect or change autism at all, but it can improve mood overall, and it decreases seizure burden. So the extent to which seizure burden is causing mood disorders and causing, you know, cognitive impairment and so on, it will affect that. But the diagnosis of autism is not directly responsible for treating. Now, we use neuromodulation. I mean, I use neuromodulation for patients with chronic pain syndromes in the setting of occipital neuralgia, or spinal cord stimulation for patients who have neuropathic pain syndromes that involve the spinal cord. And also, we talked about deep brain stimulation for primary dystonia, which is a movement disorder. And so those are the other sort of applications that I use different, you know, industry technologies in order to affect the way those nerves or, you know, brain tissue work.
Right. Yeah, that makes sense because of just the overlap, like you were saying, just the association even with autism and epilepsy being, I've read as high as 35%, that it would make sense that they would work in a very symbiotic way. That makes sense. Just looking at this list that I sent you, I think you answered all of those questions. Are there any other questions from anyone else? Things that just came up?
I do have sort of a futuristic question about down the road, like 10, 15, 20 plus years. How do you see AI moving into, in particular, functional neurosurgery, and especially at your mentioning of robotic surgery? I mean, sometimes I kind of, it sort of scares me a little bit, this idea of moving into or getting into a field that could potentially be, I guess, automated away, although I'm not sure. I have no idea where or how that fits into this, or where you see things.
Well,
going?
there's opportunities for automation in neurosurgery, but there's still too much art to the fields to be replaced by sort of like robots and computers. Like for example, the actual like cranial fixation, like immobilizing a child's head. There's no good evidence on how many pounds per square inch to put the head in, or like where to put the pins, or which pins to use. These are all still open questions, which you would think, why is that an open question? But it's just not been well studied, and there's just too much variation from patient to patient. So that still requires like a fully trained pediatric fellowship trained neurosurgeon to immobilize a little tiny pediatric skull without causing complications. And so that's one example of how like AI and robotics really can't take that over. I mean, they just, right now they can't. I mean, in the future, maybe they could, but not now. AI will be really effective at helping plan trajectories like stereo EEG and like the placement of electrodes. So for example, I'm doing this RNS next week, thalamic RNS in a very complicated brain. And in order for me to plan it, I have to, pick a point on the outside of the skull, pick a point in the brain, and then scan through that and make sure there are no blood vessels like in the way. And that takes me hours of my time to make sure that it's something called an avascular trajectory. But a computer could do it so fast because the blood vessels are bright, the rest of the brain is not. You could teach a computer like choose a trajectory in this cone or region with this target without blood vessels in it, and the computer would be much better at that than me. So that's an area where, like, yes, AI would be exceptionally good at that. And actually, it's being studied. Actually, there's early versions of software that do that for us. They're just not clinically available. So that's one example. There's robotics, of course, like I showed you the cranial robot that I use here, but it doesn't do much. It goes to a trajectory that I defined, and then it stays there while I work through it to drill and to place an electrode and all that stuff. But it cannot physically do any of that stuff. And I think that that's really far away. I also don't think it's worth anyone's time to sort of do, because there's just never going to be a time where there's not a surgeon guy in the OR doing this stuff. So then it doesn't make sense to, like, I don't know, train sort of a half capable robot to do it.
Yeah, I think also people that sort of speak of this sci-fi world of AI taking over and replacing doctors, I think they severely underestimate just how much data you're going to have to take to train it to be able to do certain things, and just some of the logistical things of, like, say it's a robot, and is the robot programmed to do more than one surgery? How many surgeries is it programmed to do? And how often are you seeing those surgeries? And how much did the robot cost? When does it need an update? I mean, I think there's so much more to it, just logistically wise, that, I think it would be very, very far away.
Yeah, I agree.
Thank you. All right, we're coming up on the hour, so I don't know if there's any last words of wisdom you'd like to share, or anything else.
Oh, I guess, like, I think that I'm not sure like who the major demographic of people were, but if there were any people who interact with children who have epilepsy, just keep in mind that coming to see a neurosurgeon or an epilepsy program does not obligate you to have surgery. It just opens the window into the opportunities that are out there. I saw a patient today whose family was like, I had to scrape them off the ceiling every day I came to see them because they were so anxious. We did a stereo EEG, which led to a temporal lobectomy. Patient was having, hundreds of seizures a week, and has not had a single seizure since surgery, and is a totally different kid, talking, talking more, staying up late, more energy, better tone to his sisters, easier to control his temper. And they're just trying to understand, like, why is that the case? Like, and the answer is that seizures are bad. So I would just say any wisdom there would be like, try to counsel families that they should come see us and
Yeah.
just see what we have to offer.
For sure, for sure.
Mm.
And that's another way that the Epilepsy Foundation here, we can also be a partner with you. We can provide information, education, we have case management, counseling, just so that there can be another ear to talk to, another shoulder to kind of lean on. So we're all partners in this together.
Yeah. All
Thank
right.
you.
Thanks
Thank you so
everybody
much.
for listening.
Yeah, thanks for your time. And again, this is recorded, so it'll live on our YouTube page, so anyone could always go back and watch it.
Cool.
Thank you.
Thank you, Jack. Thank you,
All right.
Aisha.
Have a great night.
Thanks,
Thank
y'all.
you.
Bye.
Thank you.